Hey everyone, and welcome to this explainer on atrial fibrillation. Today, we're taking the incredibly dense clinical text of Chapter 258 and translating it into a visual roadmap of a true cardiac electrical storm. So, if you've ever wanted to clearly understand exactly how and why the heart's rhythm goes so off track, you are absolutely in the right place. Let's dive in. To get through this efficiently, our agenda covers 4 progressive sections. First, the mechanics of AFib. Second, categorizing the arrhythmia. Third, stroke prevention and NOACs. And fourth, advanced interventions and electroporation. All right, starting off with Section 1, the mechanics of AFib, also known as the electrical storm. At its core, atrial fibrillation is basically a chaotic electrical storm in the heart. What's happening is a highly disorganized, rapid, and totally irregular electrical activation. And because of the sheer chaos of these signals, the upper chambers of the heart, the atria, actually lose their coordinated pumping ability. They literally stop mechanically contracting the way they're supposed to, which completely throws off the normal hemodynamics of the heart. So what's the actual consequence of all that atrial chaos? Well, this electrical storm aggressively bombards the AV node, which kind of acts as the electrical gatekeeper to the lower chambers of the heart. The AV node just gets completely overwhelmed, driving the ventricles to beat highly irregularly. For most patients, this rate sits somewhere between 110 and 160 beats per minute, though sometimes it can even spike over 200. This erratic, rapid pace severely tanks the heart's overall output. It's exactly why these patients experience such intense exercise intolerance, fatigue, and shortness of breath. There isn't just one single root cause for this condition. Instead, we're looking at a multifactorial, perfect storm of risk factors. We're talking about aging, obesity, hypertension, diabetes, sleep-disordered breathing, and even alcohol use. All of these factors act together as a final common pathway. They literally rewire the heart, causing cellular and tissue remodeling that triggers this abnormal excitability. Essentially, the atrial tissue starts exhibiting enhanced automaticity, firing off these rapid rogue beats that ignite the fibrillation. Moving right along to Section 2, categorizing the arrhythmia, which follows a progressive clinical pathway. It is super important to understand that AFib is a progressive condition. We don't have a predictable, durable cure that works for everyone right out of the gate. If you trace a patient's journey, we categorize the disease by its physical impact on the heart over time. We usually start with paroxysmal AF, which self-terminates in under 7 days. Then it can progress to persistent AF, lasting up to a year, and finally to long-standing persistent AF, which drags on for over a year. Notice how the duration correlates directly with actual structural changes. As time goes on, the left atrium goes from a normal size to severely enlarged, and the scar tissue burden goes from low to high. Look at the drug efficacy row. It plummets from often effective down to usually refractory. This is exactly why early intervention is absolutely critical before that tissue remodels permanently. Okay, Section 3, stroke prevention and NOACs, or how we mitigate the greatest risk of this disease. Remember how we established a minute ago that the atria lose their mechanical contraction? Well, because of that loss of squeeze, blood flow becomes stagnant, particularly in a little pouch called the left atrial appendage, and stagnant blood forms clots. For patients with high CHADS2-DS2 VASC risk scores who don't receive anticoagulation therapy, their annual risk of suffering a stroke can reach a staggering 20%. 20%! That is massive. This is why stroke prevention isn't just an optional add-on, it is the absolute cornerstone of AFib management for saving patients' lives. So the real question is how we manage that immense risk day to day. When we compare therapies, we essentially have traditional warfarin on one side and novel oral anticoagulants, or NOACs, on the other. Now, warfarin has been a historical mainstay for decades, but it takes days to achieve a therapeutic effect, demands those frequent, tedious PT/INR blood tests, and comes with a whole laundry list of food and drug interactions that make patient compliance really tough. On the flip side, direct-acting NOACs, drugs like dabigatran, rivaroxaban, or ipixaban, provide prompt, highly reliable anticoagulation without the constant blood draws. But, and this is a crucial caveat we cannot ignore, these NOACs are cleared by the kidneys. That means they require very careful dose adjustments for anyone with renal impairment, especially in our elderly populations who are already at elevated risk of bleeding. Finally, let's hit Section 4, advanced interventions and electroporation. Time to target the source. For a lot of patients today, especially those in the paroxysmal stage of AFib, catheter ablation is actually considered a first-line therapy, often proving superior to antiarrhythmic drugs. During this procedure, electrophysiologists use complex 3D electroanatomical mapping to carefully guide the catheter and electrically isolate the pulmonary veins. By creating incredibly precise lesions, they can completely block those triggering ectopic beats from ever entering the left atrium. It effectively cuts off the electrical storm right at its physical source. Now, the absolute latest frontier in this ablation process is a massive breakthrough called pulsed field electroporation. It's a real game changer. Instead of using thermal energy, like burning or freezing the tissue, this technique uses high-energy, ultra-short electrical pulses. These pulses specifically target and disrupt the lipid cell membranes of the faulty heart tissue, inducing permanent cell death. The major advantage here? Because the energy is uniquely tissue selective, it spares critical adjacent structures, like the esophagus, nearby nerves, or arteries, from collateral damage. It is a highly targeted, significantly safer approach to permanently destroying the source of the arrhythmia. Which brings us to a final thought. We've traced this condition all the way from its underlying multifactorial cellular triggers right up to these incredible 3D mapping and electroporation technologies. As innovative procedures like pulsed field electroporation continue to rewrite the rules of the game and significantly boost our success rates, we really have to wonder, as we move away from just managing symptoms and inch closer to true, permanent rhythm control, will atrial fibrillation eventually evolve from a chronically managed disease into something we can completely cure? It's certainly an exciting time in cardiology. Thank you so much for joining me on this explainer, and I hope this visual journey has sparked your curiosity to learn even more about the incredible landscape of cardiovascular medicine.